Welcome everyone to a Lifebulb seminar focused on supportive care during the cancer journey. And I'm really excited to have two really respected and experienced individuals with me here. My name is Karin Ienberger, and I'm the CEO of Lifebulb. But more importantly, I'm joined by Dr. Diane Reidy and from Memorial Sloan Kettering, as well as Leah Evert. And both of them come with different experiences, one as a physician treating many, many patients, and obviously also doing research and experiencing a large number of cases through her own treatment, but also, of course, the hospital, as well as the focus on one individual experience in Leah's case, but also as the founder of a not-for-profit in the cancer space, having also representation from a large number of patients. So welcome to both of you, and please, maybe Leah, if you could start just saying a few words about your experience and what you do in this space.
Sure. Yeah, thanks so much. I'm Leah. I am a lot of different things, but one thing that I like to share is I'm in a 6.5-year thriver of metastatic breast cancer. I was diagnosed with stage 4 breast cancer in 2017. I found a lump on my breast, very similar to how anyone else would experience this. However, I was 36. I was what I think to be pretty healthy. I'm a registered dietitian, former exercise physiologist, and I was a former Division I athlete. And so I thought, this can't happen to me. I have no family history of this. Went in and got it checked. And by the time we were able to do our full suite of screenings, they found that my liver was riddled with cancer. I also had a nodule in my lung and multiple lymph nodes. When I was diagnosed, at the time, the treatment protocol that I still am currently on was still new enough where my oncology team was not hopeful for my future. They had seen some good progress for some early responders, but I was still given about 2 years to live. The thought was that I would have an initially positive response and then it would return. And so I have gone through over 109, I think I've gotten 109 rounds of infusion chemotherapy, 19 rounds of radiation. I've had 5 surgeries. I had 1 recurrence. And this has become a defining part of my life. I mentioned that I was a dietitian. I also work in the corporate health and wellness space. I run a corporate health program for a large pharmaceutical company. And so I also have passions there, ensuring that I'm providing positive behavior-based education, training, and programs for a large audience. So that's where also my passions lie. So thanks for having me.
You're actually representing not only the patient, but also some of the supportive care efforts that we would hope and wish that all patients could receive. And so thank you for that introduction. So Dr. Reidy, please introduce yourself as well, and really coming from a different perspective, but equally important.
Yeah, I think it's going to be a great conversation because we're certainly complementary, and Leah's the reason I do things every single day, because you are thriving, and that's just an amazing story and quite inspiring. My name is Diane Reidy. I am a GI medical oncologist here at MSK. So I care for most patients that have cancers of the GI tract, colon, pancreas, small intestine. And my research interests are a rare type of GI cancer called neuroendocrine. And I also take care of a rare type of an endocrine tumor called adrenal cancer. So I absolutely love that we're having a conversation around supportive care. A very good friend of mine recently was at ESMO, which is like a major cancer program, if you will, and symposium on the greatest research. And it seems like many times everybody wants to be in the innovative new approaches, and then the supportive care ones don't really get the attention that they need. But I think it's probably one of the most critical things that we do as cancer docs, because it has to be about quality and quantity. So my research efforts are in trying to improve outcomes for our patients so that they can live many, many years like Leah's living, but also making sure that their quality of life is in everything that we do, and integrating that from the time of diagnosis is so critically important to ensure that, you know, we're doing that part of the bill, that we are addressing the side effects of whether it's the treatment or the cancer, or sometimes both.
I think that's an interesting observation, or maybe to clarify for listeners, or to our listeners, you know, the cancer is a journey, right? So there are certain periods of time when, you know, certain things are more important. But you were saying that already in the beginning, upon diagnosis, supportive care needs to be integrated. And when we talk about supportive care, this is a question for both of you. How do you define that? I mean, what are the kind of different verticals underneath supportive care that are, first question is, what are they? And then I would say the second question for a hospital, I mean, one of the best in the world, Memorial Sloan Kettering, what are the ones that you're very comfortable with? And maybe, Leah, from your perspective, what are the ones that maybe hospitals don't always integrate and could do better? We start with what is supportive care. Maybe Dr. Reidy, if you can take that.
Yeah, I think that all along the journey, the idea and the hope is that supportive care is going to address any symptoms and concerns that patients have from the very beginning. And so I think that, you know, I'm a cancer doctor, but I'm a supportive care doctor. And so I have to make sure that we're identifying those blind spots. And quite frankly, a lot of times, as a cancer doc, I'm so worried about the life-threatening symptoms that can happen, you know, the infections or bleeding or other things, but there can be a lot of other symptoms. And so I always use the analogy of like a grade 2 fatigue. Imagine, like, if you really look at by definition what that means, for a patient to live day to day with grade 1 to 2 fatigue is quite debilitating sometimes. Like, you don't want to have grade 1 to 2 fatigue. And often as cancer docs, you're like, okay, but you're not in the hospital with an infection, but it is equally important. So addressing those symptoms, whether it's fatigue or GI related symptoms, I think is a critical part of that. And I think along those lines, supportive care is often done by team care, and that has become so critically important nowadays. So probably the most important supportive care clinician is the nurse that is very often talking to patients a lot more than I am if I'm doing my research or what have you on a non-clinic day, to sort of address those needs that the patient may have, whether they're emotional or physical, because I think we want to take care of the whole patient, but really trying to dig down deeper into, you know, what additional care and treatment can we provide outside just not just the cancer care, but the supportive care is everything else that goes along with it. Like I said, that can be related to the treatment, can be related to the cancer itself, or sometimes just with that overwhelming diagnosis and how we can address that. Because, you know, you could say that the mental aspects of the anxiety and some of even something called anticipatory nausea, there's a lot that goes on. And I think identifying them and then addressing them appropriately is where we want to go, and not starting too late. You know, people, I think, erroneously often think of supportive care or palliative care as something that you do at the very end because you're really sick and you're about to, you know, potentially pass. And so that's when it comes. And in fact, that's absolutely not the case. The idea is to do this as early as possible, so we're able to take care of the whole patient. Leah, I don't know if you wanted to add anything to that.
Maybe even preventively.
Exactly.
Leah.
So much of what you said just resonated with me, particularly when you're speaking about, you know, for me, of course, I have a very serious illness, and sometimes I forget I have a very serious illness. I'm running, you know, a 10K this weekend. I live what I consider to be a very normal life. However, you know, at one point in time had innumerable Mets, and, you know, we were trying to just keep me alive, right? And so I don't think that physicians do really understand or know what to do with me, because it's, you know, they want me to stay alive, but they are also kind of balancing this level of hope that I have built up year after year. And, you know, I come into an appointment, I actually switched an oncologist this year, and she out the gate went into conversation around what my next line of treatment would be when this line failed. And I wanted to talk about, I think I'm an exceptional responder, and like, what if we consider weaning things off? Like, so we had a very different vantage point. And I understand that in her experience, women like me are typically declining much faster and are not in the same state as me. And so it's been a very difficult journey, but I feel like I'm also an educator sometimes too, to some of my care team members, and they are learning a little bit from me. The other thing too is that I've gained a lot of knowledge about my very specific illness because I only look at articles and read research that's specific to exactly the subtype of breast cancer that I have. And I realize that not everyone has it. And so I found niches in Facebook groups and so forth that have the exact type of cancer I have, and that have, you know, the exact, like mine was de novo stage 4, so diagnosed stage 4, at diagnosis. And also I was under 40 upon diagnosis. And so there's a little bit of a subgroup of us that have kind of found each other. That doesn't exist anywhere in my metropolitan area, that small group of people, because it's so specific. And so when I was first diagnosed, I was kind of ushered into a peer-to-peer support system. And they tried to find someone who had stage 4 cancer, and it was like a 75-year-old woman. And then they've tried to find someone that was supportive, and it was also a woman in her 30s, but she had stage 2 breast cancer. So I just couldn't relate. And so these kind of hyper-focused connections are really important. It doesn't have to be nearby. I don't have to go get coffee with the person, but be able to have a conversation. And something someone told me when I was first diagnosed was, you want to talk to someone who has the same diagnosis as you, or worse, and is doing as good as you or better. You don't want to talk to someone who has a different diagnosis at all or is doing poorly. And I know that that's, very, very narrow, but that was really helpful for me to have a really good understanding of what I was dealing with and what my future would look like. I'd also say that term palliative care is scary. I'm technically on palliative care for 6.5 years. And I remember seeing that in my chart. I oversaw it when my nurse was like writing something in, and I was like, oh my gosh, I don't think of myself as a palliative care patient, but I truly am, right? Because we're not trying to cure me. We're just trying to make sure I don't die. And that was really scary for me to understand. But we did not have, at least upon diagnosis, I didn't have a great understanding of like what my level of control could be in this situation, right? So like, I knew that I was going to receive chemotherapy. I knew I was going to receive this additional therapy. I knew at least somewhat of a process, but when I asked, hey, what can I do? Can I change my mindset? Should I be doing meditation? What nutrition strategies? Should I be exercising? Blah, blah, blah. I think to your point, Dr. Reidy, that my oncologist was like, we just want you to stay alive. And I was like, okay, cool. But like this, I'm also in business school. I was a captain in the Army Reserve. I was doing all these things. And like, that was core to my identity. And like abandoning those to just focus on living was not the way that I wanted to handle this diagnosis. I wanted to like still have this purpose. And so I think it's really good to have that level of insight, because I think those things, I finished business school, like, did a bunch of things that were really important to me, gave me that level of hope and that level of like forward thinking, that optimism that may or may not have made a difference for me. So I feel very strongly that, each person is individual and has a different experience, and we can kind of learn from each person individually.
And I would just say, just that transparency of having that communication with your primary team is so critical, because, often patients they're terrified that if we say too much, then we're going to lower the doses. But in fact, that may or may not happen, and that may or may not compromise efficacy. But more importantly, there are so many other tools within the supportive care realm in terms of medications and optimizing things that we can use if we know about it. So having that conversation about, who the patient is and what they're feeling and what may be going on that we may not be seeing is actually so critically important. And I love that example, because, many times, particularly when we're not necessarily going for curative intent, even though we're always still trying, but we absolutely can tailor the therapies, and it will not compromise overall survival. And like you said, like, it's going to be so important for you to run that 10K, because I actually am a big believer that that's going to help the treatment too. So I think that having a sort of full scope of the issues that are really important for a patient and what they may be experiencing can really help the primary team just care for the patient better. So I'm a big believer in that communication.
Question for both of you, because I first of all, totally, of course, agree. And this is I'm not a cancer patient, but I'm a transplant patient. And I just, small anecdote, when I got my second kidney transplant, one of my friends, the first thing she said was, so how are you going to get the third? That is the kind of question you don't want. It is almost like with your second doctor, this is going to fail. So what are we going to do next? So you don't want that kind of energy around you. And that's really up to, I guess, training of the medical, system, really, nurses and young doctors, and kind of creating an atmosphere of hope and constructive dialogue. And I think respect for the patient. This is not just a number. This is not just a person who's going through the treatment. This is an individual. And I think, going back to your point, Leah, each person is an individual. They fight in different ways. And I think many people, probably most, would benefit from not only thinking about their own situation all the time related to the cancer, but actually have other interests, right? If they can get there, because mentally it's so much easier to be able to distract, right? And then your body maybe handle it. But back to my question, you said it's important to gather all this information, but how do you, a patient, you're very articulate, Leah, you're very educated and, knowledgeable, but most patients don't remember. They sit there in front of a white coat and, a doctor or something, and they don't even remember what their symptoms are. And they may have only a very short period of time. And even with the nurse, they don't remember. Are there any good tools for essentially taking down these kind of symptoms, taking down the issues that you have? Or, Diane, Dr. Reidy, how do you kind of encourage patients to come to you with more data, so your team can really address it properly?
Well, I will just say I'm horrible at this, because when I go in front of my doctor, I always want to please my doctor because I've done so well and I want to be their star patient so badly. And so I'll be like, oh, nothing's wrong. I feel great. And that's terrible, because I should tell them that 6 days ago I had these horrible GI symptoms and things were awful. And also too, comparatively speaking, I was on Taxotere for 6 months and it was, lost my hair and it was just really awful symptoms. And then I was on a cocktail of 7 medications as a part of a clinical trial for 1.5 years. And so those experiences are so much worse than what I'm experiencing right now that I'm on a 2 medication regimen, and it's generally, easy to tolerate. But so in my brain, I'm thinking, oh, I'm doing wonderful. I feel great. But in truth, I'm probably, there's many, I would love to just not have to take medications and have any side effects whatsoever. And so that comparison is not great. But, journaling is great. I need to be, I have been better about that, where you just, and it can be in journaling about mindset also. And then you can just be like, oh, I also had these GI issues this day. And then bringing that in, because typically I do want to go in and say, I've been feeling wonderful. We're doing great, and just make everybody happy. And that's not a great mentality. So I need to do that and remind physicians, because, 30 days or however, 60 days in between appointments, there are definitely ups and downs that I need to articulate a little bit more appropriately.
Yeah, I would totally agree. And, it's amazing the amnesia we all have in life, right? We just forget. You're like, oh, it wasn't that bad. And so usually a caregiver or a partner, your other half, whatever it might be, to have them there to keep you honest and be like, actually, like you said, no, 6 days ago, you had, you were vomiting for a couple of days, and so having the sort of remembrance of that by journaling. And then when you're saying that, the frequency, the intensity, and ideally when it happened along the cycle can actually be critically important for us as your primary care team, because there's actually, we've developed so many better medications to help a lot of the related symptoms from chemotherapy. And so knowing exactly when it happened, there are certain drugs that can happen if it's something called delayed nausea, for example, or if the diarrhea starts right afterwards, or it maybe is a week later. And so trying to sort of catalog it, and it's hard, I know, because we all have lives and it's hard to sit down and then actually write it, but knowing more or less when the symptoms occurred and for how long could be very helpful for us to know how we might be able to intervene and improve upon it for the next cycle.
That's good. That's good advice. And again, trying to get help, because you may not be able to do it all by yourself. So asking someone, and I'm sure there are apps for this too, in cancer, and makes it easier. And some things are maybe even seamless. If we go back to this more overall question on, what are the supportive care needs when it comes to the actual cancer versus, it doesn't really make a difference, but I just would like, a little bit of an understanding of what does a cancer cause that we know, for example, pain, if you have metastases in the bones or in the liver, there's going to be pain. And what are some of the typical symptoms that are caused by some of the traditional cancer therapies? And then as a follow-up, what are some of the symptoms that are emerging with the new treatments, the ADCs and so on, targeted therapies, even some of the CAR Ts and so on. Diane, if you want to take that first.
Sure. And that's a loaded question, and it's a great one. It's a really important one. I think we could probably do a whole episode on that in and of itself for a couple of hours, but I think you're absolutely right in that there are cancer related symptoms that we need to address, such as pain, sometimes nausea, sometimes depending on where your disease may be located, it may affect the ability for you to move your bowels or to have the energy that you need. If it's in the liver, sometimes it can cause some nausea because the liver can get inflamed, et cetera. So, and that's sort of hard sometimes for the primary team to be able to tease apart, like how much of this is cancer related versus chemo related. But I do think that, sometimes patients will say, the chemo is really, really hard on me. And it sometimes, unfortunately, can be a signal to us that when they say it was really hard because it was really painful, or it was just like tremendous fatigue the whole time, we have to ask ourselves, is it really the chemo, which would be easier for us to fix as opposed to the cancer? So, sort of really, again, trying to chronologically understand what those symptoms were and for how long can help us kind of differentiate the two. I think, pain management is by far one of the hardest still today in oncology to assess and then treat. We're just not good at it. Our society in general is not good at it. We need to do better, because patients should not be suffering when we know that we have a lot of different types of pain medications to address. And if they don't work, try something else. And even interventions in terms of what anesthesia can do now, certain sort of injections and other things. And we even have spinal taps to sort of alleviate some of the side effects from some of those pain medications that you can use. And so there's lots of different therapeutic ideas and innovations that are going on. So it's not just a pill. And I think even our patients in general are so terrified about the possibility of some sort of dependence or addiction that they aren't letting themselves get the pain relief that they need. So I think that one is really important, to try to be as honest and transparent so that you can talk to your doctor about, one, you have the pain, and two, the therapies that we're giving you are not working, so that we can adjust and iterate, because we can do better if you're still in pain. The second piece in terms of the chemo-related side effects, or traditional, starting with traditional chemos. So the traditional chemos we tend to use in the category of what we call cytotoxics. So like Leah said, the Taxoteres or the 5-FU-based therapies or gemcitabine. These are traditional therapies that we've had sometimes for decades. And people say, how can you still use them when they can cause hair loss and they can cause nausea and vomiting and diarrhea? And the answer is because they work. So like Leah's here with us for 6.5 years because they are helpful. Now, we always want to do better, and we want to get ahead of that and try to alleviate the side effects and think of alternative therapies. But these are treatments that are still very life-saving and can be critically important. So we have to manage, what are we going to do for the hair thinning? And do you have the opportunity for doing scalp cooling, which could potentially prevent hair loss, or the GI-related symptoms and some of the medications that we have to prevent those GI-related symptoms or to treat them if they happen? So the traditional cytotoxics tend to cause that kind of, potentially, not all of them, but the hair loss, the nausea, vomiting, fatigue, sometimes the GI disturbances, which can be constipation and diarrhea, and sometimes it's a battle of the both. And then the lowering of the blood counts, which can, for us, lead to more serious infections and bleeding and that kind of thing. Then we have the so-called immunotherapies, or the checkpoint inhibitors, which are newer kids on the block, if you will. And they're brilliant in that if, for most patients, they have very little, if any, side effects. And we want to turn on the immune system to be able to attack the cancer. And often it can work absolutely beautifully. Sometimes, though, we're turning on the immune system too much. And so we only want to go into second or third gear, and we end up going into, say, fifth gear. And if we turn on the immune system too much, you can cause problems such as severe diarrhea, or such as something called the colitis, or severe damage to the liver. And so those types of side effects can be very dangerous and life-threatening. And so lowering the sort of response to the immune system by high-dose steroids is the way that we treat it. But then you can imagine, as you know, I'm sure, Karen, the side effects of steroids, which can be debilitating in and of itself. So we have to sort of be mindful of that. And again, very, very important to share any side effects that you may have to your primary team if you are on immunotherapies, because we just don't want to miss that. Because if you gave it again and you have already immune system that's a little bit too much in gear, it can be very, very serious. And then we have another whole set of things called targeted therapies. And the idea there is that the drug or the treatment is kind of going against a sort of, whether it's a protein or a gene, but they also have their own side effects. So again, I sort of talked about earlier on grade 2 fatigue, or grade 1 nausea, or grade 1, what we call hand-foot syndrome, which could be like pretty bad peeling. And you're like, oh, it's only peeling and dryness of the hands, but it can kind of get annoying, and it can get a little bit painful and discomfort. And mouth sores. So, but they're all treatable. We just have to know about them. And then, like you said, lastly, we have even newer version, which we're very excited about. It's something called CAR T cells. So again, sort of takes advantage of your own immune system. They can literally take out your own, what we call your T cells, a type of your white blood cells called T cells. They take them out of your system by something called apheresis, they genetically modify them so that that T cell, that immune system cell, can actually see your cancer, and then they give it back to you so that it can go and attack those cancer cells. And again, in some patients, it's been a game changer, particularly in what we call the blood cancers, the leukemias and lymphomas, and childhood leukemias and lymphomas. But again, if that goes into overdrive, you can get something called a cytokine storm, where you can get very high fevers and get very sick, and that needs to be done in the hospital. So you can imagine, like, lots of different side effects, lots of different reasons to be very open and communicative with your doctor so that we can appropriately treat them, because they all have different sort of concerns as it relates to the supportive measures that we need to take.
Yeah, thank you. That's a great overview. I wish we had that in written form. I'm not sure that it exists somewhere, but it's nice to actually see the progression of the therapies and how the side effects. Nothing that works ever goes without side effects. I mean, that's my experience across very many disease areas. If it doesn't really cause any harm, it normally doesn't do any good, unfortunately. We hope we get there at some point. There's always a risk involved with drugs. So Leah, I wanted to ask you, I mean, during your treatment and your continuous treatment, first of all, what are some of the most, I guess you talked about hair loss, you talked about fatigue. It doesn't seem like you're that tired right now. So, you know, and now you're kind of living very well, but I'm sure there are smaller things. You know, what is the level, what is it has, when it comes to communication, again, going back to that, you know, what do you feel is the best way to get the attention of the doctor? I know you want to be a star student, but you know, what is the point when you say, okay, it's enough, now I just want to get the attention of the doctor, and how do you kind of saying this is what is happening right now? What is it?
I think that's a good question. I mean, I think having a supportive team, and whether it's a nurse case manager or a mental health professional that's working within your team, and those being your advocates that can be able to communicate messages to your team to make changes, that's super important, right? Like, I think the first mental health professional that I reached out to was someone who worked in the cancer center where I had treatment, and so was able to look at my chart, make recommendations, say, hey, maybe you should talk about this. And so that was very important to me. The kind of rise and better access to, or better user experience for some of the like patient portals is also very helpful. And if you are relatively tech savvy, being able to message back and forth, I know is appreciated by my providers, because they can't always pick up the phone, but or call me back, but are very quick to respond, something quick, an email back and forth. And via the patient portal creates a wonderful system for sharing. And that way, at this point, I'm only seeing a provider every 60 days, whereas before I was seeing a provider every 3 weeks. And so we're just, slowly making it a little bit larger, making the gap a little bit larger, but having that ease of access and the better user experience around some of these patient portals has been really important for me to make sure that all of the times that I have any sort of issue or concern, they're being addressed at the moment. Because again, like I mentioned, there may be a time in my cycle, I have treatment every 3 weeks. There may be a time in my cycle where I don't feel great, and then I show up treatment, I feel wonderful, and I've just had amnesia. So being able to kind of address it in the moment has been really helpful, and having a team that kind of manages that and does a good job with that patient experience has been very good. And I think for me, it's interesting. I think of it myself as a consumer, right? Because I am a frequent flyer at the hospital, and so I want to have a good patient experience, similar to how I would experience brand loyalty for something that I am participating in my regular life. I think that hospitals and various treatment centers have a long way to go to mirror that. But that expectation, I think, is something that us patient advocates can continue to talk about, because, we do spend a lot of time and money at these facilities. And so our needs should be integrated into the long-term strategy of the facilities.
So that's a good way, actually, of
100% on everything.
Conversation, and we have 2 more seminars in this series that, by the way, sponsored by Helsinn, which is a pharmaceutical company over in Europe, headquartered out of Lugano, Switzerland, and their key focus is supportive care. And we appreciate companies that truly focus on that, because there are so many that focus on the next, therapeutic. But I wanted to, and we do have these additional 2 sessions, so we can dig deeper into some of these specific supportive care issues, such as GI, symptoms, as well as muscle wasting, which is a really difficult one to address. And it is something that Diane educated me earlier, that it's really due to the cancer versus the actual therapy. So, and that's important to know, because then you don't have to reduce the medication. And, I want to make that very clear. And I think we heard it today, but for those of you listening, if you have a symptom that is due to the cancer in itself, of course, continuing with the therapy is very, very critical. And if the symptom is due to your therapy, then that is a problem, because then you may need to reduce the therapy. So that's why it's so important to, as I think we heard earlier today, the timeline for the symptoms and exactly what the symptoms are, so that with that extensive knowledge that your team has, they can put it in place and really diagnose where it comes from. So I wanted to kind of ask a final question to both of you, just to finish this, even though I'd like to continue, is if you could change something, Leah, in how you've experienced the specific, the addressing your supportive care needs within your center. I mean, thinking about you now as the N of one, and you did say that, it is our job as patient advocates. If we are flying United, we can have specific requests. We want the warm cookies, like American Airlines, or the warm nuts. We don't get that anymore because now everyone has nut allergies. So what would you focus on as the number one?
Well, I'm biased to this, because as a registered dietitian and working in the health and wellness field for years, I felt like my access and encouragement to complementary medicine has always been limited. And I realize that there are more progressive and proactive care teams that will point you to resources, but even so, I really wanted to have a say in the overall outcome of my care, right? I wanted to say, hey, are there nutrition strategies that make sense for me? Should I be considering some sort of metabolic style of eating, or should I be exercising? And truly, exercise for me during I had about 4 months of the taxidermy, lost my hair, blah, blah, blah. Exercise for me was crucial, but no one wanted to say that to me. You should be going out and doing runs. They were like, take it easy. You should walk, because I think they want to tread lightly and tiptoe around someone who has cancer. And I get that, right? But every person's a little bit different. I do wish that there was a little bit more in my experience. I think this is changing, encouragement around various complementary strategies and lifestyle strategies that can certainly both help with alleviate symptoms and side effects, but also may have a contributing factor to your overall survivability. And that's what led me to co-found the Willow Foundation, because we fund studies that look at the effects of these various strategies and the outcomes that they have on cancer patients. In fact, we funded 3 studies at MSK, Dr. Reidy, so I know some of your colleagues. And I think that if there was a standard of care that included these types of strategies, and not just go talk to the cancer dietitian and they'll tell you to eat more fruits and vegetables, it's like, hey, maybe consider this nutrient, and it just empowers the patient to have some level of input and control over their situation versus just allowing medication to run its course. I truly believe that the two together are integral in finding the best way to survive or thrive with a debilitating illness such as cancer.
I really appreciate that. I think that was well said. Thank you. And for you, you are sitting in the middle of this kind of really strong cancer center. But if you could, and this is now, not an MSK seminar, so you can mildly not criticize, be constructive. What would you change if you could within your? I mean, you're already doing it probably, but if you could move faster, what is the one thing?
No, I mean, I actually think what Leah said is really true. I think one, as you know, Karen, I started a podcast called Cancer Straight Talk, and the whole purpose of that was to empower and educate our patients on these really important topics that, quite frankly, in clinics sometimes just, I don't know if it's just that they're not as important and we've run out of time, but on the role of nutrition and exercise and plant-based diets and sexual health and all of the things that are so critically important to ensure that our patients have a strong quality of life. But as best as we can, use the available data, because, at MSK, we're so blessed. We have someone who's an exercise physiologist who's actually testing what that 10K is going to do on Leah's, disease. And hopefully, it's going, and we have really powerful data on that, or what the role of a plant-based diet versus ketogenic, and actually how ketogenic could potentially hurt our patients. And so having that type of information, because quite frankly, it may not be as sexy as some of the pharma trials that are driven with ulterior motives sometimes, right? I mean, I think that many in pharma are there for the right reasons. They also want to build the treatments of tomorrow to increase the cure rates of everything that we have. But there's other, issues there on drug kind of sponsored trials and even our own investigator-initiated trials as it relates to the drug therapeutics. And that's sort of what I went to the beginning of the conversation on. When you go to these major cancer symposiums, it's very heavily genetics based and innovatively based. And it's not based on things that we know are critically important for patients' quality of life and can actually help patients live longer. Ethan Bash, who was at MSK, showed that you can improve overall survival by introducing palliative care earlier, just by addressing those needs of the GI-related symptoms that patients have, with overall survival benefits that are far greater than some of the therapies that we now have as FDA-approved drugs. And yet, we're not giving as much time and effort into that space. Harder to run the trials, but it doesn't mean that we can't do it. So I think when we're creative and we think about things like that, and I have a passion of even thinking differently about the way we deliver the cancer care. To Leah's point on, we could be so disruptive in the healthcare industry to be more patient-centric and to deliver it in a way so that patients aren't in our waiting room for hours on end. So I think there's a lot of different things that people don't even realize and patients are willing to tolerate because they're sort of like, well, I have to, it's my life, but it actually doesn't need to be that way as an industry. So I think that there are more opportunities for us to test it, just like we would do for a drug A or drug B, but particularly in the supportive care space. When you look even in supportive care teams that are, we didn't get a chance to talk about it, but, I talked about as a primary oncologist to be a supportive care doc as well at the same time, but there are supportive care docs, that's all they do because it can get so complicated. And I think, you want to make sure that if you're a primary oncologist and primary team aren't really addressing those needs, often there's another team that knows it even better and they can focus on those symptoms and that pain management and those GI related issues in a way with a little bit more expertise sometimes, depending on the team that you have. So that's something to be very helpful for. And, being able to support them and what they're doing and having the right conversations and really being mindful of things like what are important to patients in terms of their values. Leah shared with us what's going to be important to her. So I think that's all under the umbrella of supportive care, and being able to provide the funding and the right studies to test all that stuff is something that I would be excited to see.
This is great. I really, really thank both of you. And I think we need to all check out Willow as well as Cancer Talks. And of course, also Cancer Life,
Yes.
which is a platform for patients to connect and share experiences. And again, thank you to Helsen, but primarily thanks to Leah and to Dr. Reidy. And I hope that we can continue this conversation. I think there's much more for us to do together. So have a good evening, everyone. And this episode was recorded, so people can see it again, and we will also summarize this in writing. So thank you, have a good evening, and I'll see you very soon. Bye-bye.
Bye-bye.